Hi guys, my name is Sanjay Gupta. I'm a consultant cardiologist in York, and today I wanted to talk to you about AFib, anticoagulants, and antidotes. And as I talk you through this, it'll make sense. Now, the first thing to say is around about 2 to 3 people out of every 100 in the population have AFib. When we get to above the age of 80 years, then 25% of people above the age of 80 will have AFib. Okay. The problem with atrial fibrillation is that it predisposes you to the risk of strokes. All right. And therefore, to reduce the risk of strokes, it is recommended that patients take anticoagulants. Now, doctors also refer to anticoagulants as blood thinners, okay? However, they're not truly blood thinners. They will not make your blood thin. What they do is they stop your blood clotting if you bleed, all right? So, in essence, it will make you bleed more, but it doesn't necessarily mean that you're carrying thin blood. And that's an important thing because some people get worried about it. And certainly when I've referred to anticoagulants as blood thinners in the past, I've had a lot of people, particularly one gentleman wrote to me and said, look, you know, you're scaring people. And I didn't realize that was a big thing, but I did some reading, and I think that he's right. I need to correct myself. And I think it's wrong to say that they're blood thinners. They're anticoagulants. If you bleed, your blood will not clot as quickly if you're on an anticoagulant, okay? Now, it's very interesting because until very recently, the only real anticoagulant which was used or which was recommended in patients with AFib to reduce the risk of strokes is Warfarin, okay? Of course, some people used to use aspirin as an anticoagulant, but aspirin is not an anticoagulant. Aspirin is an antiplatelet agent, and we know now that aspirin has no benefit in preventing strokes in patients with AFib. So until very recently, the only real option was Warfarin. The problem with Warfarin is that although it is an effective treatment, the anticoagulant effect can be very variable, okay? And therefore, the dosage of Warfarin has to be adjusted based on how thin it makes the blood. So a person gets put on Warfarin, they then have to come and have a blood test. That blood test is called the INR. And if the blood test is not between a value of 2 to 3, the dose of the Warfarin is increased, and then the patient comes back, and then if you find that the INR is above 3, then the Warfarin dose is reduced. And so there's a lot of jiggling about. Initially, when you start on Warfarin, there's a lot of this, but after you achieve a period of stability, you don't require so many blood tests, but you still require blood tests. One of the other problems with Warfarin is that there are lots of interactions with various foods and with various medications. So, you know, if you are unwell and you've had to take some antibiotics, or if you've changed your diet recently, then that can affect the amount of Warfarin and its effect on the blood. It's an anticoagulant effect on the blood. So a lot of people find that they're restricted in what they can eat. They find it very inconvenient to have to go to hospital or to their GP and have regular blood tests. I did a little study a couple of years ago where I wanted to find out how many blood tests on average a person would require before their INR range was constantly between 2 and 3. And I found that after starting, patients would generally require up to 11 separate blood tests, okay, to try and get that value stabilized between 2 and 3, which is a lot. So that's the other disadvantage. The third disadvantage is, of course, with anything that has an anticoagulant role, it can cause you to bleed as well. All right. Sometimes it can be unfortunate. You could fall or you could have an accident. And if that happens, then you could bleed torrentially because the blood will not clot as quickly as it should. Of course, there's also the risk of having spontaneous bleeds if you are on medications which are anticoagulants. So until recently, people had no choice. They would have to go on warfarin. And most people now recognize that if you have AFib and you're deemed high risk enough to require anticoagulation, then you're doing so for life. And therefore, people were often subjected to being on warfarin for life, which is a big undertaking. More recently, we now have newer alternatives. Okay, and these agents are called the NOACS, or the new oral anticoagulants, or the novel oral anticoagulants, also called the non-vitamin K anticoagulants. Okay, and there are 4 in the market. The first one was something called dabigatran or Pradaxa. Then we had rivaroxaban, apixaban, and there's a 4th one called edoxaban. The advantage with these anticoagulants, there are lots of advantages. The first advantage is that, and the advantage that most people know of, is that they don't require the monitoring that is associated with warfarin. So you can give these agents, and the patient just takes them on a daily basis. And provided the patient takes them regularly and at the dose that is recommended, we know from trial data, all 4 agents have been studied extensively, and we have a robust database of up to 80,000 patients to say that they work as very effective anticoagulants. So they do the same job in terms of anticoagulation as warfarin would, but they don't require the regular monitoring. The second advantage is that they don't have any major interactions. So the kind of interactions that people have to endure with warfarin don't necessarily exist. And so there are no real dietary restrictions. Of course, it's never a good idea to drink excessive amounts of alcohol. But other than that, there are no real dietary interactions. So that's a real advantage as well. One of the other things to say about the newer agents is that I know these are the 2 I've mentioned are commonly recognized as the most important advantages, but there is a much bigger advantage. So it's very interesting because I did a study recently where I asked all my colleagues, my consultant colleagues, and I said to them, well, if you had a choice, let's say you were diagnosed with AFib, these are all cardiologists, by the way. I said, well, what agent would you go on, knowing what you do about all these available agents? And all of them said, we would like to go on a NOAC. We would not like to go on warfarin. We would prefer to be on a NOAC. And I said, well, that's interesting because, at this point in time, what I do is if I have a patient in my clinic who has AFib, I say to them, go and speak to your GP, because this is what is recommended by everyone, that the GP should then counsel the patient on all available anticoagulants, warfarin and the 4 different NOACs, and then the patient has to decide which one he chooses. And the patient choice is important because the National Institute of Clinical Excellence in 2014 have very clearly specified that the patient's preference needs to be taken into account. Why is it then, this is me asking my colleagues, that so many of my patients choose warfarin? When their consultants, we would choose a NOAC, why do so many people come and choose warfarin? And I did a study and I asked these patients who were choosing warfarin, Why did you choose this agent as opposed to another agent? And what was very interesting was that the majority of people who chose Warfarin chose it because they were told that there was no antidote for the newer agents, i.e. Warfarin. You can reverse, well, you can't reverse, but you can use something called vitamin K and reverse the anticoagulant effects. With the newer agents, until recently, there were no such reversal agents that would reverse the effect of the anticoagulant. And that resulted in a lot of patients, even now, coming back and choosing Warfarin as their agent because they didn't want to be on something that had no reversal agent in case they bled. And the advantage that they were told about the NOACS was that there was no monitoring required. So the patient often was left with the dilemma, well, I could go on an agent where it's convenient, I don't have to have any monitoring, but it is potentially unsafe because there's no reversal agent if I were to bleed. I just want to correct that because I think that that is not necessarily how a cardiologist would make his decision about the NOACS, okay? And I hope that through my insight you will benefit. We know from the trial data that NOACS cause 50% less likelihood of causing bleeding within the head, within the brain. Okay, people who are on an anticoagulant, if they're going to bleed, okay, are going to most likely either bleed in the head or in the stomach. There is a substantial difference between these two sites. If you bleed in the head, if you're unlucky enough to bleed in the head, then only a small amount of blood is needed, and that would be enough to kill a person. All right. The head is not a very accessible place, so the brain is not very accessible. So if you bled, it's not easy to get rid of the bleeding or stop the bleeding by, you know, doing something to the brain. And you only require a small amount of blood to cause a catastrophe. In the stomach, it's very different because the stomach is accessible and you need a much larger volume of blood loss to cause an effect, to be dangerous. Okay, so in the stomach, you can afford to lose a lot more blood, and because it's accessible, you can still seek help and get help. In the brain, if you're unlucky enough, then you just a small amount of blood into the brain and you die from it. So what we know is from the studies, NOACS cause 50% less likelihood of bleeding in the head compared to Warfarin. And as a cardiologist, if I had AFib, the main reason I would choose to go on a NOAC over and above Warfarin is because it is less likely to make me bleed in the head. All right. So people worry and people get turned off from the NOACS because they're worried about this antidote or reversal agent. Until recently, there were no reversal agents, and they get put off by that. This is no longer true. The first thing to say is that dabigatran, which is has a reversal agent, it is called idarucizumab, okay? And the company Boehringer did give vials to all accident emergencies free of charge to use. However, and with the other agents, there is going to be an antidote available towards 2017. They're not really antidotes, they're reversal agents. So the first thing is that one of the NOACs does have a reversal agent. And the reversal agent will work within 20 minutes of being given. So it takes the agent out of the equation. So if you're unlucky enough to be bleeding whilst you're on dabigatran, if you go to your A&E, they give you the vials of the reversal agent, idarucizumab, and within 20 minutes, the anticoagulant effect of the dabigatran has been taken out of the equation. It's been neutralized. All right. If, however, so that's one thing to be aware of, all right? And there will be other reversal agents coming out in 2017. But even if there were no reversal agent, it is important to bear in mind that the reversal agent is not going to make a huge difference to your outcome. Why? Because the reversal agent, for example, if you're unlucky enough to bleed in the head, then, as I say, only a small amount of blood is necessary to cause death, and therefore you don't have the time to get a reversal agent to reverse things, and a reversal agent will not really make a difference to an outcome. So you might as well take an agent which is less likely to make you bleed in the head in the first instance, i.e. NOACS make you less likely, substantially less likely to bleed within the head in the first instance. So you might as well do that rather than take an agent which is more likely to make you bleed, like Warfarin, but then has the vitamin K, because the vitamin K is really not going to make any difference. So it's just worth bearing that in mind. A lot of people get put off by the idea of taking NOACS because there is no reversal agent or antidote. A, it's not true. There is a reversal agent for dabigatran. It's very effective and works within 20 minutes. Two, even if there were no reversal agent, you're better off taking an agent that is less likely to make you bleed in the brain in the first instance. All right. So that's something to be aware of when you make your decision making. Of course, the second advantage of the NOACS is the convenience. You don't require the regular blood test. There are no real interactions. The third thing to say is that, again, in my study, I found that if you start on warfarin, it can take up to 35 days to get the blood tests within range. So you are unprotected from the risks of stroke for up to 35 to 40 days. Whereas with the new agents, you take them and within a few hours, you've got your cover. All right. Some people say, well, how do I know they work? There is no blood test. The truth is, we take so many medications and we just believe they work. You know, we don't do a blood test on every tablet we take to see whether it's working or not. If you have any doubt, of course, if you cut yourself by any chance, you will find that your blood will not clot as easily. The NOACs have generally a short half-life, and therefore just stopping the NOAC will get rid of it out of your system after a few hours. So they have a short half-life. There are some patients in whom you can definitely not use NOACs, okay? All the guidelines about use of NOACs is use of NOACs in non-valvular atrial fibrillation. And there's a lot of confusion as to what non-valvular atrial fibrillation means. But practically, valvular atrial fibrillation for the purposes of prescribing NOACs or not prescribing NOACs consists of rheumatic mitral stenosis or metallic heart valves. If you have rheumatic mitral stenosis or mechanical heart valves, metal heart valves, you should not use a NOAC. You should be on warfarin, full stop. We know from a study called the Realign study, where they gave a NOAC to patients with metallic valves, and NOACs were associated with harm. Okay, so you cannot use it in metallic. You cannot use them in metallic valves. You cannot use them in patients who have rheumatic mitral stenosis. But all other valvular conditions, you can use them in. The second thing to say is that they shouldn't really be used if you have bad kidneys, because a lot of them get excreted from the kidneys, and if you've got bad kidney function, then you won't get rid of the NOACs. So it's just worth bearing those things in mind. I hope this is useful for people who are contemplating whether to go on warfarin or NOACs. To my mind, if I were ever given the option, I would definitely choose a NOAC. One last thing. I want just to be one last thing. A lot of people get put on something called apixaban, 2.5 milligrams twice a day. Although this is a dose that can be used, the evidence base for this dose is very small. The evidence base is based around a study, a subgroup of patients, of 400 patients only. So to my mind, if you're going to choose a NOAC, you should take a proper dose where you're getting full benefit of the agent. All right. Not many people know this as well. So, you know, when you're sort of chatting with your GPs, when you're chatting with your doctors, I think it's quite useful to have this extra bit of information to be able to make an informed choice. Ultimately, to my mind, eventually it doesn't really matter. As long as you're on an anticoagulant and it is doing the job, it is keeping your blood and it is keeping you anticoagulated. It doesn't matter which agent you go on. However, if you're trying to work out which agent you want to go on, then I hope this video will help. And that's about it. So thank you so much for listening. I hope this was useful. This is me, Sanjay Gupta. I'm a consultant cardiologist. This is my website, yourcardiology.co.uk. And this is my Facebook page. So if you have any comments, please send them to me and I'll reply back. And I wish you good night. Thank you.